Good afternoon, everyone. Thank you so much for joining and for your interest in this critical topic. My name is Fahmi Hanna. I'm a technical officer at the WHO Department of Mental Health and Substance Use, and I'm the focal point for access to mental health medicine at the Mental Health Unit. It's my pleasure to welcome you today to WHO Special Initiative for Mental Health Learning Webinar Series, Essential but Not Available, Medicine for Mental Health. Colleagues, for many health conditions, the question whether a medicine work for millions of people around the world living with mental health conditions, the question is often more basic. Can we get access to it at all? Medicine cannot improve life if it never reaches the person who needs it. Before we hear from our distinguished and experienced speakers today, I would like to introduce a WHO framework. In the next slide, please. The WHO used to think about access to mental health and neurological medicine. Colleagues, too often access is reduced to one question: do we have the medicine? In reality, WHO look at access similar to the International Convention on Economic, Social, and Cultural Rights. Access depends on 5 interconnected domains. Availability: are medicine present in the facility and the supply chain? Are they included in the EML, Essential Medicine List? Accessibility: can people reach service and obtain them? For example, prescription authority, integration of mental health into PHC, referral protocols. Affordability: can the system and the individual afford the medication? Acceptability: do people trust the medicine and use them without stigma? And quality: are they safe, effective, and properly monitored, such as through laboratory monitoring for some of the medication? Colleagues, the medicine may be available nationally, but there is no trained prescriber through mhGAP nearby, so access remains limited. A medicine may be available and prescribed, but people cannot afford getting it, so access becomes incomplete. And even medicine become available, accessible, affordable, but stigma within the family, within the healthcare facility, within the pharmacy, misinformation can still prevent the person from benefiting from an available and affordable medicine. Through this WHO framework we are sharing with you in this slide, and we share with member states in our practical work in countries, we continue to see both challenges and solutions across all the 5 domains. In today's webinar, we bring these issues to life together through experiences from Ethiopia, from Zimbabwe, from Ukraine, and from WHO's global work on access to medicine. Colleagues, we will begin with a lived experience from Ethiopia, and we will hear from our colleagues in Zimbabwe about essential medication list and supply chains work, supply challenges work that is being currently solved through the Special Initiative for Mental Health, and then to Ukraine experience with Special Initiative, scaling up mental health services during a complex humanitarian emergency. Finally, my colleague Rodrigo Cataldi from WHO headquarters will discuss practical actions that WHO is taking globally to strengthen access to this. Colleagues, please feel free to post questions in the chat throughout the session. We have dedicated time for discussion at the end. Before discussing policies, budget, and supply chain, it's important to remember why this work matters. Colleagues, behind every mental health medicine stock out and every interruption in treatment is a person, a family, and a community suffering. This is a human rights issue, aligned with international human rights standards, as stated in the International Convention on Economic, Social, and Cultural Rights, CRPD, among others. It's my great pleasure to introduce our first distinguished speaker, Eleni Mizganau, President of the Mental Health Service User Association, and thank Eleni using this opportunity for her great support during my recent mission together with my colleague Rodrigo in Addis Ababa, where she supported our work together with the Association on Access to Medicine. Eleni, floor is yours. Thank you for joining us today.
Thank you, Dr. Fahmi. Hi, everyone. It's a pleasure for me to speak on this very important topic close to my heart. So next slide, please. I will be sharing with you some of my journey. I'm a person with lived experience of bipolar disorder I'm living with the condition for the last 30 years, but I'm proud of the life I have built. I have to be honest. In terms of education, I have a bachelor degree in economics, and employment-wise, I served in the state-owned Commercial Bank of Ethiopia for 7 years. And then I shifted from the finance sector to the NGO sector after I have obtained my master's degree in sociology. Personally speaking, I have built a stable life. I am blessed with a caring husband and a beautiful daughter. I also serve as a choir leader at my local church. So next slide, please. Why am I sharing these experiences? Because these achievements are precious to me. However, one thing I would like to focus on is that these achievements would have not been possible without the stability my medications provide throughout these years. My medication acts as the anchor that keeps me grounded. Living with bipolar disorder is really manageable when the right tools are available. My recovery relies on being proactive. I monitor my early warning signs closely. I reach out to my doctors, to my therapists, the moment I or my family notice a shift. When my medicine is consistently available, which is not the case all the time, I do more than just survive my diagnosis. I am able to actively participate in my life and contribute to my community. The stability from my medication allowed me, the real me, to shine through independent of the highs and the lows of my condition. Next slide, please. So these 30 years haven't come with no hurdles. So for 30 years, I have fought for my stability. Yet I can say that around 80 to 85% of my episodes, my depression, my manic episodes, were not inevitable, to tell you the truth. They were the direct result of unavailable medicines and broken laboratory monitoring systems, because I took lithium carbonate for 15 years. And as you know, it has a very narrow therapeutic range. And I needed to have a laboratory test of serum every 3 months, but this were not available for an optimal management. When my trusted medication disappears from the market, my world becomes unstable in all sense of the word. I am often forced to accept suboptimal first generation alternatives, and these older drugs carry side effects that are really intolerable. They treat my survival as the only goal, ignoring my quality of life. Next slide, please. So this is not only the case, but there are many times where I had to resort to informal, private, black market, contraband purchases just to fill the gaps. These costs are a constant, heavy financial strain on my family and on my own life as well. And even worse, sometimes the correct dosages are often missing from the market. So I am forced to cut tablets with a knife to get the right amount, the right amount. This usually leads to so much waste and dangerous and inaccurate dosing. I can conclude that this is not just a supply chain failure. It is a failure to protect my dignity and my health and my well-being. So I would like to call for action for everyone here. I know that my ability to lead a stable life that I have described, productive life, has been consistently challenged by the need to navigate gaps in medication availability and the limitations of suboptimal alternatives. I have been pushed to pay overpriced, out-of-pocket costs just to maintain my basic health. This is my call to action. Mental health medications are not optional. They are life-saving essentials. They must be treated with the same urgency as medications for any other chronic, life-threatening condition. Governments must guarantee a consistent, reliable supply of these essential drugs. I have more in the next slide. And procurement must be needs-based, not just based on historical demand or lowest cost data. We need prices that are affordable for every person with lived experience. Service users must have a seat at the table in procurement decisions. Their organization, their collective voice should be reflected in proactive demand surveys. And we demand, as service users, quality assured medicines that actually work, because it doesn't happen always. Sometimes we resort to ineffective, cheap alternatives because of cost restraints. Policy must move from paper to practice with dedicated budget lines that ensure we never stock out. Invest in our stability so that we can continue to contribute to our families, our work, and our communities. Final slide, please. So I would like to call for action to walk the talk. We all agree that mental health medication is essential, yet essential remains a hollow promise when the shelves are empty. If we truly believe these medications are life-saving, we must act like it. We cannot continue to fail those of us who need these tools most for our basic survival. True progress is not found in policy documents. It is found in consistent, reliable access at the point of care. It is time to bridge the gap between what is written on paper and the reality of our daily lives. My call is for us to move from consensus to commitment. Let us make the essential that we agree on truly available. Thank you very much. Over to you.
Cleni, thank you very much. We really hear the Mental Health Service User Association of Ethiopia loud and clear. Invest in stability. There are many quotes in your speech that will always stay with me. I have fought for my stability for 30 years. I heard that loud and clear. I also appreciate your attention to many details that you shared with us that can turn into follow-up policy and recommendation action. Your talk about dosing and need to cut it by the knife. Your talk about laboratory investigation, which was not there. I truly appreciate sharing with us that medicine shortage is not supply chain problem. It affects people, recovery, well-being, and daily lives, and is a life-saving issue. I also recognize that I missed your choir while in Addis, and I'm very much looking forward to listening to your choir next time I'm in Addis Ababa. Thank you, Eleni, and I'm pleased now to introduce our colleague, Dr. Debra Mashando from WHO Zimbabwe, who will share with us the experience of updating essential medicine list and addressing the supply challenges in Zimbabwe. Debra, over to you, please.
Thank you, Femi. Good afternoon, colleagues. I would like to share with you our experiences in Zimbabwe. So the book that we use for prescribing medication, we call it the EDLIS. Please, next slide. So I'm going to share with you. So what we have done in Zimbabwe regularly is that our EDLIS is regularly updated. Every 5 years, we get a new edition. So you would notice that the update is achievable on paper, yes, but the actual implementation of what is updated is the question. And when the EDLIS is updated, it is done by specialists who use evidence-based mechanisms to try and come up with the best ways of ensuring that people with mental health conditions get the best evidence-based treatment. So there is a national commitment to ensure that we've got the best in terms of guidance for healthcare workers to prescribe. Next slide. So what has the EDLIS achieved? We have managed to update treatment using recommendations that are evidence-based and that are current. We have managed to expand primary care access. So selected medicines now are available at primary care level, ensuring that mental health services are available at accessible distances. Then there's also been alignment with evidence-based and disease burden. So the medicines are aligned to current evidence and to national disease priorities. There is also supports, the EDLIS supports the task shifting and decentralization in such a way, in the form that it empowers non-specialist healthcare workers to be able to prescribe basic medication. And there has been improved integration of mental health. So it allows for strengthening mental health care within the primary health healthcare, as well as support across the continuum. So what does this mean practically? If you take fluoxetine, for example, a medication for depression, it is procured at the primary care facility. So the primary care facilities are able to order that medication by themselves. And following our special initiative for mental health in Zimbabwe, we have trained nurses at primary care facilities to be able to prescribe. So now the EDLIS has been updated so that primary healthcare providers who are trained in mhGAP can actually prescribe medications like fluoxetine. That way, depression does not, common mental health conditions like depression do not have to be referred to specialist services, which is what used to happen in the past. Okay, so while we have managed to do that, our mhGAP trained healthcare workers can prescribe. The medications have now been listed in the EDLIS and treatment guidelines are available. We continue to face the gap that was mentioned earlier. The medicines are not available at facilities. So prescribing power is there, but the medication is not there. Patients are therefore referred unnecessarily because they cannot access the medications where they should access them, and their treatment is obviously interrupted. So we are learning that mhGAP plus the EDLIS by itself, it's not enough. We need the medication to be enough so that we can have the complete picture of improved outcomes. Next slide. So we have tried to look at some of the challenges in the supply chain for medications. And we note that huge amongst the challenges is irregular financial releases. While the government has an obligation and a commitment to provide medications, the budget towards mental health psychotropic drugs is not sufficient. And it's not just the budget. There's been it's unfortunate I'm going to use the word consistent for inconsistent release of funds So there is delayed or even insufficient funding, which disrupts the entire supply chain. So it's actually common in Zimbabwe for drugs to not be there than be there. And you find that our patients then default treatment because they don't see the need to go for their follow-up visits because they know that most of the time the medication is not there. And because of that inconsistency, there's also weak forecasting and quantification, inaccurate estimates because there's not been the proper implementation for people to then track effectively. Procurement delays also slow the process. And then there's distribution challenges. One of the challenges that we noted is that in one province, you might have some facilities having medications expiring, while some facilities have stockouts. So there is weak systems in terms of ensuring equitability of the distribution of for medications. You can go to the next slide. Okay, so priorities for Zimbabwe, what we think could be the solutions is to strengthen the financial envelope, specifically for medications, and not just strengthening the envelope, but ensuring that the medications are, the finances are provided timely, and that there is sustainable investment, that we can have faith that it's going to continue to be there, that will improve the supply chain and also ultimately improve the service delivery. Next slide. Okay. Thank you. So yes, so those are the challenges for Zimbabwe. We are grateful that we've made strides, but we are worried that our mhGAP trained nurses have not adequately practiced what they've been trained on to provide, to prescribe the medication. And that may affect the impact of the services that we have taken so much pains to improve. Thank you.
Deborah, thank you so much for the very good presentation and the great game-changing work that you highlighted. I like particularly some of the concrete example you gave as the fluoxetine example of introduction in the email and the scale-up of procurement and availability. I think your presentation, Deborah, highlighted that updating policy and medicine list is important, but implementation is what ultimately determine access and success, which is the ultimate goal of the special initiative for mental health of enhancing universal health coverage for mental, neurological, and substance use. Thank you, Deborah, for the insights and the great work. And I'm now delighted to introduce my colleague, Dr. Elisa Ladik-Brizgalova from WHO Ukraine, who will share with us the experience of rapidly scaling up mental health services and managing access to medicine, including supply chains in exceptionally challenging context. Elisa, particularly, I want to thank you for joining us. I know how difficult it was a night yesterday and the night before in Ukraine. Thank you for joining us despite all the challenges. Just show how resilient you and mental health colleagues in Ukraine are.
Thank you so much, Fahmi. and we will be presenting and prepared for this presentation with my colleague Alexei Kostyuchenko, who is also present here. And with the next slide, I would start saying that all the work around medicines in Ukraine and psychotropic medicines is rooted in their overall mental health care reform and the All Ukrainian Mental Health Program initiated by the First Lady. And as you might know, that mental health is really priority here in Ukraine as a part of development efforts and, of course, as a part of response to emergencies. I will start saying a few words about the current mental health service structure. And I will start with primary health care, of course, as a cornerstone of an entry point of for mental health also in the health sector, where we been implementing mhGAP and train primary healthcare doctors and nurses to provide care. And as a part of that protocol, there is also pharmacotherapy. And as of today, 20% of primary healthcare doctors were trained in mhGAP training and basically can prescribe the medicines. And the second big part of service provision is specialized services or psychiatric care. And here we have newly introduced network of mental health centers. These centers have been embedded into their general healthcare hospitals, but basically they serve as a psychiatric still outpatient care integrated into their general health care. And of course, we have inpatient psychiatric services and psychiatric wards pre-existing, basically. And now we have that working as one system. And based on that, I will explain a bit on how the medicines work has been arranged. And please, next slide. So basically, the overall approach to national mechanisms enabling access to medicines in mental health area is briefly presented here. So we have National Essential Medicines List, which is based on WHO Essential Drug List. And it is updated also regularly, almost on annual basis. Then next one is Ukrainian National Formulary, which provides more guidance to practitioners and also inform decision makers how their medicines are expected to be prescribed in line with good standards. And also so-called dostupni liki, so it's accessible, in translation, it's accessible medicines, covering not only mental health, but including mental health. And this is basically a national reimbursement program designed to provide medicines and reimburse their cost, mainly for outpatient services, but again, not only mental health, but generally. And this program covers primary health care also, and specialized outpatient services. And next slide, please. So this is the snapshot of medicines available, and I will not dive into all the names, but basically the message here is that the availability is quite good in this case, and we have antipsychotic, 8 antipsychotics here, and 6 antidepressants, and also psychotropics for management of other mental health conditions. And second, next slide. And this is the dostupni liki, or accessible medicines program, reimbursed by the government. Also, almost the same list of medicines is available here from the essential medicines list. So basically, but here we talk still about availability and partial accessibility, but I will explain more with the next slide, where we still have some challenges, like echoing the title of this event and webinar. We prepared to share about some still barriers and gaps. So while Ukraine was quite successful in rolling out the mhGAP training and covering with the training the many primary healthcare providers, online modality and face-to-face modality, with their pharmacotherapy part, we still have some gaps, quite essential ones, because when it comes to this accessible medicines program, Dostupni Leki in primary healthcare, when it comes to mental health conditions, it's still blocked in the system, and the root of that is that in the law of psychiatric care in Ukraine, there is a specific condition that only psychiatrists can define the mental health condition, do psychiatric evaluation, and establish a diagnosis, which means that in practice, the pathway looks like that if person visiting primary healthcare doctor and appears to have symptoms of mental health condition, and even being trained, the primary healthcare doctor recognized that and suppose that certain condition is there, he or she cannot establish the diagnosis formally and prescribe the pharmacotherapy, but they need to refer this patient to psychiatrist to do that, to establish the diagnosis and do initial prescription, and only after that a person can return to primary healthcare doctor for follow-up treatment, which creates certain barriers because, as we all know, not many of those patients can actually or can go to psychiatrists or have opportunity to do so, and in this case, there is still option that the primary healthcare doctor can prescribe a recipe, and the patient can go to pharmacy and buy this medicine. But this is then not affordable, as referring to the classification that Fami mentioned in the beginning. So because of that, currently there was a national consensus conducted in Ukraine, and also with FAMI participation this month, and we're now preparing the recommendations how we can lift and adapt the regulations to enable that initial diagnostics still and prescription within primary health care. So this is our current gap, and we still the country is working on to address that. And next slide. And also, as Ukraine is undergoing all the types of hostilities, and specifically closer to the front line, where most severely affected by the war, of course, the access to psychiatric care, psychiatrists, and overall specialized care is restricted there. Due to security and other obvious reasons, and therefore primary healthcare becomes even more relevant with enabling those prescriptions and providing that essential care. At the same time, when it comes to medicines chains and procurement, in these areas, the humanitarian medicines, the humanitarian donations made as a part of emergency response also feel many gaps, and we as WHO, but also through the coordination mechanisms that we have established, like MHPSS Technical Working Group and Health Cluster, and other platforms. We try to collect the needs in medicines and address them as a collective effort and action. Next slide. I think that's the last one. And just to briefly mention that we have our experience in around the WHO mental health medicines kit, when we observe that actually we do need more and basically psychotropic medicines used sometimes more than antidepressants, which is also we continue to explore the reasons for that, but we assume that first antidepressants, they are still a bit more available through their like existing healthcare services, while antipsychotics sometimes less available. So we're thinking how to probably contextualize the scope of that kit to meet needs in Ukraine. So basically, we see more need in antipsychotics and a bit less in antidepressants, which doesn't mean that we have more psychosis than depression, but it just how it just the need in medicines and what is addressed and what is less addressed. Yeah, I think I'll stop here, and I think that was my last slide. Yeah.
Thank you so much. Thank you, Alisa. Alisa, it's really remarkable to think and see, as I witnessed also last week when I was with you in Kiev and with the colleagues in the East, that one of the world's largest scale and fastest growing scale up of mental health services is happening in the middle of war in Ukraine. It's not only the need and it's not only the flow of resources. I think it's the resilience and dedication of great colleagues and leaders like you, Lexi, among many others who are working day and night to achieve access to essential services in Ukraine to people in need. The name of the umbrella program that you kindly mentioned to us at the beginning is called How Are You? And it comes from the human rights principle that the mental health and well-being of one citizen is the mental health and well-being of all, by asking your neighbor and colleague, how are you? Thank you, Alisa. Great insights and great learning that even during difficult circumstances, significant progress can be made, and when mental health is prioritized within health system strengthening efforts. I now move to my colleague, Dr. Rodrigo Cataldi. And Rodrigo, you lead on access to medicine within the Department of Non-Communicable Disease and Mental Health on all medication. Tell us how different or similar mental health and neurological medication are to insulin or antihypertensive. How similar or how different when it comes to access to medicine. Over to you, Rodrigo, please.
Thanks, Fahmi, and thanks, colleagues. I think everyone that spoke before me made my life so much easier because you shared so many good insights. But I'm happy to share some of the experiences, and well, I can also talk a bit about the differences between the other conditions, because there are several differences, but there are also many cross-cutting issues that will impact the same way medicines for diabetes and mental health conditions. But there are also very different ones, which together with Fahmi and other colleagues, we are definitely trying to support countries on addressing this, including the special initiatives countries under the guidance of Iris and Lydia. So it's a great pleasure to be here, and I'll discuss a bit today on what we are working, but I want to keep in mind that some of the things that I'll share, they are examples. I don't think that every country is different, and the way to address this will also be different in different countries. The challenges will be different, but I think we can share and create this community of practice where we can share our perspectives and help each other in address this. I'm using this slide here to show how complex access is, and also speaking towards the title of our meeting today, essential but unavailable. And we see that the availability of medicines is one small part of having medicines reaching access. We need to have an entire health system that is functional to ensure that people living with these conditions have access to the medicines that they need. So to do that, it's very important that we work very closely with the ministries and partners on the ground to make sure that this entire value chain of access to medicines reaches the goal that we need. So it doesn't mean that every country will have challenges around every bone of this fishbone diagram, that's how we call it. But when we can use that as a template to try to understand the challenges in countries, and some countries will have an additional bone. Some countries we don't have to worry about one situation of this because we have, as a community, built the capacity of healthcare workers or strengthen the supply chain. But overall, the message that I want to pass is that we need to work with the ministries of health because we are talking about chronic conditions. And more we are seeing these chronic conditions aligned also in terms of comorbidities, people having several conditions. So we need this, this work on access to be integrated into the health systems of the countries. And that starts from the great work that ministries of health are doing in the countries that we are working with. I'm using the picture of my dear colleague Fami to show that availability does not mean access. This is a recent picture of his field visit in a country where at the central pharmacy, the medicines were there, but not at the health facility, not to the people needing the medicines. So somewhere the chain of access to medicines broke. And even though the medicines were available, they were not reaching the people they needed. Sorry for me, I used your picture without your consent, but I think it was amazing to see, not in a good way, how different countries will experience this, because in some countries they will not have the medicines at all, but in some countries it's actually the medicine is there, but it's not reaching the people they need, and they might even expire before they reach the people that they need. So we talk a lot about the EML, which is the selection of medicines, the prioritization of medicines, which are a policy document in the country that helps us to prioritize the medicine. It's a necessary step, but it's not sufficient. The addition of these medicines in the standard treatment guidelines is the first step in a huge chain of events that need to take place to make sure that these medicines reach the population that they need. Which means, and we see in this picture, medicine being procured by the ministry, by anyone in a country, does not immediately translate into access. And the availability of medicines, if it's not accompanied by them being affordable, it will also not translate to access. So medicines need to be affordable to the health system. So if we want ministries of health and central pharmacies to be able to afford these medicines, they need to be at a fair price. But also the entire policy environment around pricing of these medicines, markups and so on, they need to be in place to make sure that whenever they are available and they are affordable. So the access gaps, they arise across the entire value chain of access to medicines, being the policy side, how the procurement is done, how these medicines are being financed. If they are through donations for a period, how are we going to ensure the sustainability of it? Are we doing some kind of co-payment for these medicines so it becomes more affordable for the health system and at the same time to the population so they don't have to do everything out of pocket? And I think this is just a snapshot showing that in many countries, medicines for mental health, they are more often than not available. We look here at this in this example, except for one formulation of amitriptyline in a specific country that seemed to be available, very quickly we reach to a availability of less than 10% of these medicines, which means that 10% might be concentrated in the capital, which means that someone living 12, 15 hours drive from the capital cannot drive every month or every 3 months to reach the medicine outlet to get these medicines. And we can also see that they are virtually unaffordable to the population, except the very first generation of psychotropic medicines that seem to be affordable in these specific countries. All other medicines are not affordable. There's also the issue of adherence and acceptability. And this great work led by my colleague, Dr. Fahmy, we are working on developing a material to address misconceptions, because you can have the medicines available, affordable, but if we have stigmatization around these medicines, we cannot have this, people would not continue to take these medicines. If you go to a pharmacy and the pharmacist or the doctor prescribing has the misconception of mental health is the medicine for crazy people, as in some countries they will say, you will feel that you should not be having these medicines. And more often than not, they are trying to, healthcare people, they are trying to persuade you to not take these medicines. So it's important that all of us create this community, that we share the information that these medicines are effective, they are safe, and everyone that needs them should have access to them. Now, we talked about the EMLs. The EML is just a piece of paper if it's not implemented. So between having medicines added to the WHO EML and into countries' EMLs, there is already a gap. Further from that, if we do not use the country's EML, if countries are not basing their own essential medicine list as the basis of their procurement, reimbursement, the clinical care, the core purpose of the EML will not be realized. And what it actually works is the implementation of the EML, alignment with the clinical guidelines, the universal health coverage, the procurement systems, and the supply systems. And have all these systems aligned, we'll make sure that the medicines that we are prioritizing for clinical use are also prioritized at the policy level. They are also the ones being reimbursed, and they are the ones being delivered in a regular basis to the health facilities. When there is a disconnect between this, the system breaks. So if a primary care provider wants to prescribe whichever medicine they need, they think it's the best one without that being aligned with the country policies, this medicine is very unlikely to be available at the medicine outlet at the healthcare facility. And how can we use mhGAP, which I believe all of you know, to drive better access? So we can use mhGAP as the clinical guidance for countries to then align the essential medicine list and make sure that one is reinforcing the other. So when they are aligned, we make sure that what we are prioritizing for reimbursement, for procurement, are actually the medicine that we should be prescribing. Also, the mhGAP can also harmonize the path for access. It provides, especially the non-specialist workers, with evidence-based standard use for these medicines and the selection of these medicines on how to use it and when to use it. mhGAP also supports the adherence by also the use of making sure that these medicines are used in a safe way and prescribed according to the guidelines. And the alignment between all of this will make sure that this will reach the people they need. I'm finalizing the presentation just to say that beyond all these clinical conversations and the policy conversations that we talk about, there are also issues around the supply chain that go beyond mental health medicines, but for sure impact mental health medicines. So, for example, the registration of these medicines. In many low and middle income countries, these medicines are not registered, therefore they cannot be procured legally. Many times they have a single supplier, creating a supplier monopoly. Also, how do we know how many medicines we want to buy in the future? We need to make sure that we can forecast our demands for the future. And this is something that we are definitely supporting countries on how to do. So appropriate forecasting sends the right signal and help the ministries of health to quantify both on the finance side, but also to support their negotiation with manufacturers. Last slide, how can we work together? What are our quick wins? There's a lot that can be done, but if we can focus on a few, healthcare providers can support the update of the standard treatment guidelines in countries, the uptake of the standard treatment guidelines, alignment of the formularies of the health facilities, because many health facilities will have different formularies, and also the specialists can engage in training of primary care workers. Civil society can support in advocacy to include these medicines in the UHC, in the benefit packages with the support from people with lived experience, running awareness campaigns and anti-stigma campaigns, and also support in the accountability mechanism to hold ministries accountable. Finally, people with lived experience can do so much. They should be embedded in all of these activities, including sharing their experiences to help to shape policies, join and support peer groups and support groups, and also help to co-design the services and the guidelines that we are proposing. I'm going to stop here now and hand back to my colleague, Dr. Fahmy. Thank you very much.
Rodrigo, thank you so much for the brilliant presentation and lots of insights and practical recommendations are really there. Thank you for sharing my photo in the warehouse in one of the countries. I promise I don't take that many pictures next to medication boxes in warehouses, but that particular one was an eye opener because you talk with practitioners, and at that time it was risperidone, was very much severe shortage in that particular country. And then we went to the warehouse and discovered majority of risperidone was expiring in the warehouse. And the link here was not about actually the availability of email or procurement or availability of resources, but it was actually an issue of linking procurement to practitioners' needs. Rodrigo, great insights from your side, and thank you for the good presentation and great work on this. Actually, I have a question to you, Rodrigo, and I thank Giovanni and Lydia for compiling all the questions here in the chat for us. How does WHO engage with public sector versus the private sector in developing countries, e.g., in the African continent, to increase access to those essential mental health medicine? Any successful examples from developing countries, Rodrigo, please, in the next 2 minutes?
Thanks, Fahmy, and thanks for the question. So WHO, the engagement with the ministry and the public sector, I think that we have shown here. So maybe I can focus on how we bridge this with our engagement with the private sector. For example, one of the biggest challenges is the registration in countries. Every country will have different regulatory capacities and regulatory levels, and also in terms of the demand. Many times the manufacturers do not see a demand signal for them to go and want to supply to these countries. So two quick examples. We are engaging several manufacturers that would like to expand the supply to sub-Saharan African countries, for example, but they find it very cumbersome and very complex to navigate the regulatory environments. So what we are actually doing, we are meeting with them one-to-one and showing what are the WHO initiatives that we can support them with. For example, the collaborative registration procedure and reliance mechanism, meaning that you don't have to go country by country that you want to register anymore to do the registration. We can support them doing a bulk registration, let's say, in 10 different countries, and do this intermediation with the National Regulatory Agency, with FDA, for example, and others. This is one example. The other one is in terms of the demand signal. We are supporting countries in estimating the demand for these medicines. And we are doing this communication with manufacturers to show all the great work that the colleagues here are doing. For example, we are training healthcare providers. We are aligning EMLs. We are including medicines in the benefit packages. So therefore, the demand will grow. Therefore, you should be present in these countries to make sure that whenever the country starts the procurement for these medicines, the supply will be there for these medicines to be procured. These are a couple of examples, but we can have a separate conversation.
Great.
Thanks.
Thank you, Rodrigo. And the last question is from Dr. Shawa, Dr. Jackson Shawa in Zambia. And it is about the availability of laboratory infrastructure when it comes to clozapine use, and what Dr. Shawa interestingly described as clozaphobia among undertrained clinicians. Are there any strategies WHO have seen or applied in countries to use sustainably and secure clozapine supply and it being prescribed adequately? I'll take this question. Clozapine is part of mhGAP clinical recommendation, and clozapine should be prescribed under monitoring of specialists in mental health. And clozapine should be prescribed and used while we use white blood cell count. And that's based on the mhGAP recommendation. It's important to emphasize that mhGAP is designed for non-specialized healthcare setting, meaning it can be used by non-specialists under a specialist monitoring, but through the guidance in mhGAP for monitoring of white blood cell, because a granulocytosis is a fatal phenomenon if the person exposed to infection. So while we don't apply what is in specialist clinics, we apply more relaxed frequency of white blood cell count, but white blood cell count is unnegotiable when you take clozapine. It's important to note that clozapine availability is critical, and there is shortage, as we saw in my colleague Dr. Cataldi presentation and slides, that there is shortage of clozapine in many facilities. But clozapine is essential because it's the only medication we have for resistant schizophrenia. I agree with you. There is a bit of clozaphobia we see in practice, but white blood cell count based on mhGAP recommendation, availability of clozapine are both very important. Colleagues, before we close, let me leave you with 3 key messages. First, essential mental health medicine are exactly essential. Second, access is about much, not only having medicine on a list, it requires a functioning system across all the 5 domains we discussed today. Colleagues, people with lived experience emphasize it today, and we always should make sure that they remain at the center of all the efforts to scale up access to services and access to medicine. The true measure of success is whether people can consistently obtain the treatment and care they need and they want. Thank you to all our speakers, participants, great colleagues from Mental Health Innovation Network. Joy, thank you for all your efforts in organizing this webinar. Giovanni and Lydia, you are stars. Thank you for selecting the topic and arranging this webinar. We look forward to continuing this conversation and working together to ensure that essential mental health medicine become not only essential on paper, but available in practice for universal mental health coverage. Colleagues, thank you so much. Thanks our speakers again. And until the next webinar from this learning series. Thank you.